Θα συνεχίσουμε με το επόμενο τραπέζι, το οποίο είναι ένα φροντιστήριο στην ουσία. Έχω τη χαρά να είμαστε μαζί με τον κύριο Μαρίνο, που όλοι τον γνωρίζετε, την καθηγήτρια, την Τζούλια Σκαρίσμπικ. Θα μιλήσω και λίγο στα αγγλικά, και γιατί και η προσκεκλημένη μας ομιλήτρια είναι η κυρία Τζάκι Χόπκινς, η οποία είναι παθολογοανατόμος, εργάζεται στην Αμερική σε πάρα πολύ μεγάλα κέντρα. Ήταν και πέρσι μαζί μας και θα μας μιλήσει για τις φλεγμονώδεις δερματοπάθειες, τη υπογκοειδή μυτική τίαση και τη διαφορική διάγνωση με περιστατικά κυρίως, και έτσι θα πορευτούμε το επόμενο 2ωρο περίπου. Θα έχουμε σχολιαστές, έχουμε την κυρία Νικολάου και τον κύριο Κρασαγάκη. So it's a great pleasure to introduce Jackie Hopkins. She is a dermatologist and dermatopathologist, and she has been working for many years in the field of dermatopathology. Currently, she is in the Kissinger's Medical Center in Philadelphia. And I have the pleasure to be with my colleague and a leader in cutaneous lymphoma, together with Julia Skarisbik. She is supporting our meeting, and she was here last year also with us. And we'll all together, and Dr. Leonidas Marinos, and all together we will have a great discussion during this workshop. So thank you very much for being here. And it's a pleasure to have Jackie with us.
Kalimera. Somebody taught me this. Rome poli puime edosimera. That's okay? Thank you for inviting me. I have always enjoyed coming to Athens and Greece in general, and meeting all the great Greek people and being with my friends here. So I was asked to talk about lymphoma and how to diagnose it under the microscope. So how many people here read pathology slides? Okay, good. How many people would rather be outside in this gorgeous weather? Well, my job is to teach you lymphoma as if you were a pathologist. I know that maybe some people might be interested. So bear with me that I've also added a lot of clinical situations. So as a clinician, you still need to be aware of some of these unusual diagnoses, whether you're going to be looking at it under the microscope or not. There are some cases in which the diagnosis will not fit with what you're seeing. So I'm showing you some mimickers and some unusual presentations of lymphoma that, of course, you have great pathologists here, but you might have a pathologist who might be unaware and they might call it lymphoma and maybe it's not. So I've added some cases to show that as an example. I guess I'm getting old and I don't know whether to use these or not, so we're going to try it with them. I'm mostly going to talk about T-cell lymphomas because they're the ones that you see most often. This is the outline. I'm going to sort of give you the nitty-gritty about how to diagnose lymphoma and differentiate it from eczema. I'm going to talk about, just briefly, about some of the different types of lymphoma that are in the classification that are recognized, and talk about just the different subtypes and variants that you just need to be aware of. It's not everything, but I'm going to try to do as much as I can. This is supposed to be 2 hours, but I'm going to try to cut it down to an hour and a half or so. I don't know how long it'll be. I'll have to skip some things at the end, I think. So in general, the most common thing you're going to see is mycosis fungoides. The other common presentation you're going to see are going to be the CD30 lymphoproliferative disorders. That includes lymphomatous papulosis and anaplastic large cell lymphoma. There are a whole bunch of other types of lymphoma. The one that we all learn about is Sézary syndrome, where it's more of a blood presentation, but they're all red usually. And then there are some pseudolymphomas or reactive lymphoid hyperplasias. And as I mentioned, I'm not going to talk about the B-cell lymphomas. So when we get a slide, we look at it and try to decide right off the bat if it might be a T cell or a B cell lymphoma. The T cell lymphomas like to go to the skin, so we say that they're epidermotropic. So a lot of times there's going to be the infiltrate either in the skin. Is this also, do I have a pointer? Okay. Does this do both? Okay. So it'll be in the skin. We call that epidermotropic. It's still epidermotropic because it likes to be near the skin. B-cell lymphomas like to spare the skin, so we say it has a Gren zone, whereas as the T-cell lymphomas progress, it becomes a tumor, but it still sort of likes to involve the epidermis. And the B-cell lymphomas tend to be a little bit deeper. But for all of these, we need immunohistochemistry to decide sort of what's going on. So these are a list of the different immunohistochemical stains we use. The T-cell markers, the one most commonly used is CD3. CD4 and CD8 are the helper and suppressor T cells. So most of the lymphomas that we see, mycosis fungoides, are going to be a T helper lymphocyte rich. So we use those two to decide if it's very skewed towards one or the other. That helps us say that it's potentially lymphoma. Some of the T cell markers can also stain B cells, so that can sometimes help us if we get a tumor that's staining for CD5, for instance, which is usually a T cell marker. So we have to know about all these different markers. Sometimes they're supposed to be, T cell markers, but instead they're B cell markers, and that helps us make the diagnosis. CD30 is the marker for lymphomatoid papulosis and anaplastic large cell lymphoma, but it's also a reactive infiltrate. So sometimes you can get something like scabies reaction or drug reaction, which has a lot of CD30 cells that can mimic lymphomatoid papulosis. So these are all the different things that we need to know about to be able to give you the right diagnosis. TIA1, granzyme B, and perforin are cytotoxic T cell markers. Again, these are normal markers that are present in the skin in certain situations, but if you have a lymphoma and you can recognize the lymphocytes as being abnormal and you can show that they're showing a cytotoxic marker, that will help us know that it's a certain type of lymphoma that expresses these cytotoxic markers. Most of the lymphomas, so the T cell has two different types of receptors. One has alpha beta, and that's most of the T cells. And then there's gamma delta T cells, and that's a small percent. And likewise, the lymphomas are usually the alpha beta lymphomas, and those don't tend to be as aggressive as the gamma delta lymphomas. So we also have markers to decide what kind of T cell it is. So if it's a gamma delta marking T cell, then that tends to be a more aggressive T cell. And then PD-1, I think we've all sort of heard about PD-1. In this situation, we can use it to help identify some of the lymphomas. The one that's indolent and probably not too uncommon is a CD4 positive small medium T cell lymphoproliferative disorder. A lot of words here. And that marks with PD-1, and we can use that to help us make that diagnosis. It's not specific, but it's helpful. And then I have a lot of B cell markers, but I'm not going to go into the details of this because it's more of a pathology diagnosis. You're just going to see a bump and you're going to send it to the pathologist, and there's not going to be a whole lot more that you'll need to know in terms about if he's giving you the wrong diagnosis, he or she's giving you the wrong diagnosis or not. And so this is a list of lymphomas that will primarily involve the skin. I'm going to try to hit most of these. I'm not going to do the Hydroia vacciniforme, which is usually seen in South Americas and Asian places. And the lymphoma classifications have changed over the years, and so we try to sort of keep up with it. They're just sort of being fine-tuned. It used to be the EORTC, then it was combined WHO and EORTC, now it's WHO classification. And then another group branched off. My guess is there was probably a little bit of problems in the groups, but there was some dissent, and so now a separate group has their own designation. That's the International Consensus Classification, and it's for the most part the same. One of the differences, and I think everybody agrees, that marginal zone lymphoma, which is one of the common B-cell lymphomas, is very indolent, and a lot of times it can be triggered by Borrelia or some infection, and so that has been downgraded in their classification to a lymphoproliferative disorder. And I think overall everybody agrees that that is appropriate. And then the B-cell lymphomas, again, I'm not going to talk too much about, but just know that the marginal zone lymphoma is very common. And if you get that diagnosis, usually you don't have to be aggressive with it. It's usually a solitary bump. Sometimes it's hard to differentiate from pseudolymphoma, but it is, even though it's considered a lymphoma or lymphoproliferative disorder, it usually just stays in the skin, but it will recur. So that's the one thing you do need to know. And then the other thing I'll say is one of the aggressive B-cell lymphomas that you might encounter, it's not very common, is the diffuse large B-cell lymphoma leg type. It used to be called of the leg, but now we realize the same lymphoma, which is very aggressive, can be elsewhere, but it has the same immunophenotype as leg type. And again, you just need to know that if you get that diagnosis, diffuse large B-cell lymphoma, anywhere in the words, and it's usually going to be more aggressive. All right, so now to focus on the T-cell lymphomas, you have less aggressive subtypes and then more aggressive subtypes. So most of the mycosis fungoides and their subtypes are less aggressive, more indolent. Of course, you can still die, they can be fatal, but overall they're very indolent. And there are some subtypes, I'll try to go over as many as I can. The CD30 positive lymphoproliferative disorders are also indolent. Lymphomatoid papulosis, by definition, has to regress, and so that will never kill you because it always has to go away for the diagnosis. Anaplastic large cell lymphoma, which has similar histology, is a tumor, but even though sometimes it can even go to the draining lymph node, it's not very aggressive. It's rare to go outside of the, to disseminate. There are some paniculitic lymphomas. One of them is subcutaneous paniculitis-like T-cell lymphoma, or SPTCL, which is very indolent. It can occur even in kids and adolescents, and it's usually indolent, often will respond to corticosteroids, but it can kill the patient if they develop the hematophagocystic syndrome. And then there are two just sort of like solitary indolent dermal bumps. One is T-cell rich, the one I mentioned earlier with the PD-1 staining, and one is acral, and so you'll get it just sort of in one area. Acral skin, ear is a common place for it. It can also be on the fingers and a few other places. And that's CD8 positive, and that's also indolent. And of the mycosis fungoides subtypes, there's the folliculocentric mycosis fungoides, which, if it's not very cellular, can be very indolent. But then once it gets more bulky and plus starts to have a lot of CD30 expression, if the patient has, a little older, then that actually can be an aggressive presentation. Sézary syndrome, which is the CTCL that involves a peripheral blood, heavy dose of peripheral blood involvement is aggressive. Some of these others, adult T-cell leukemia lymphoma is not really a primary lymphoma, but it can mimic Sézary or mycosis fungoides. Aggressive CD8 positive epidermotropic cytotoxic T-cell lymphoma, which a lot of us refer to as Berti lymphoma because it was described by Emilio Berti, and it's easier to say that. That's also very aggressive. I'll give you examples of that. Gamma delta lymphoma I mentioned. The extranodal NKT cell lymphoma nasal type is an EBV lymphoma. It tends to be in Asian countries mostly. They get central facial oropharyngeal tumors. It used to be called lethal midline granuloma of the face. That's a very aggressive lymphoma. And then we have other EBV lymphomas that are aggressive. And then you can have what we refer to as peripheral T-cell lymphoma, not otherwise specified, that doesn't fit into anything, and most of those are aggressive. All right. Shall we just stop there? Sorry. Okay, so now we're going to go through mycosis fungoides and how to diagnose it. So, clinically, you guys are here because you see lymphoma? Some of you? Okay. So you know that mycosis fungoides presents as indolent lesions, usually patches, plaques, double-covered sites like the buttock, inner thigh, inner arm, breast. And it is characterized histologically by an epidermotropic lymphocytic infiltrate that is CD3 positive, the T-cell marker, CD4 positive usually. And usually tends to be negative for cytotoxic markers and gamma delta, but there are variants. And so we'll just go through the basic mycosis fungoides. In the corner is well, I can't see it. Up there is a Patriae microabscess, or also known as Derrier nest. And you have a collection of atypical lymphocytes often surrounding an Langerhans cell. So that's very characteristic, almost diagnostic of mycosis fungoides, but it doesn't come about until later in the course. So a long time ago, we used to rely on that, and now it's not till later. So if we wait to find that finding, we're going to miss some early disease. The lymphocytes are very irregular. They're cerebriform, so that like a brain, if you slice it in one plane of sections, it looks like scissors cutting through the nucleus. And so the second one down here are examples of the type of abnormal cell that we see in mycosis fungoides. So when I'm looking at the skin, I'm really studying all the lymphocytes in the skin, and if I see that most of them look like that, then I'm really concerned that it might be mycosis fungoides. The clinical is usually a combination of patches and plaques. If you just have a tumor and it's a T-cell lymphoma under the microscope, it might be the CD4 or small-medium T-cell lymphoproliferative disorder or something else. You have to usually have the patches and plaques together. Sometimes you can get tumors. And the pattern of epidermotropism can be, it can be beading along the base of the epidermis. It can pepper the epidermis. And I'll give you some examples of that. So here are some typical histopathologic findings. It can be a band of lymphocytes beneath the epidermis, but you're familiar with lichen planus, right? That's a band of lymphocytes, but it eats away the base of the epidermis. And here it just sort of leaves the base of the epidermis alone, except for, it'll be there, but it's not wiping it out with a lichenoid tissue reaction. We look for, again, those little cells that have notched edges. We have the Patriae microabscesses over here. And sometimes they just sort of almost stuff the dermal papillae in addition to the Patriae microabscesses. A beading of the lymphocytes beneath the epidermis on the epidermal side is very characteristic. Lupus will have lymphocytes at the base, but it'll be sort of picking at the base of the epidermis in a vacuole or interface reaction. Here, you've got sort of vacuole around it. We say that's a lymphocyte in every hole. They have perinuclear halos, which also help us make the diagnosis. This fibroplasia is also quite characteristic. So we look for all of these things. Here's the stuffing of the dermal papillae that I mentioned. And so here's an example of mycosis fungoides versus eczema. You have usually the rete are sort of skinny with mycosis fungoides. You have the lymphocytes at the base of the epidermis. You still have the round contour, so it's not a lichenoid tissue reaction. You have some fibrosis. And here you have a lot of spongiosis, sort of out of proportion to the amount of exocytosis. And with eczema, you're rubbing and scratching it, so it gets acanthotic, sort of a fat acanthosis, as opposed to these little skinny rete. Here's another example here, the skinny rete here. And a lot of times, instead of being epidermotropic, the lymphocytes will be sort of around the vascular plexus, deeper in the dermis. Other things we look for are scale crust. Eczema is usually going to be a little bit more acute, and so you'll have serum in the crust that sometimes it'll lift up. And with mycosis fungoides, a lot of times it's very dry. Even though we say it's scaly, it's sort of a dry atrophic patch. And so the stratum corneum often is just compact. Again, more scale crust. Sometimes pityriasis lichenoides chronica can have some overlap with mycosis fungoides, but we have blood in the horn, serum, and also vascular involvement. This is an example of like mycosis fungoides being band-like but respecting the base of the epidermis, so the rete stay very round, whereas in a lichenoid tissue reaction, it really obscures the basal layer where it's just sort of eating at it, and you have a true lichenoid tissue reaction as opposed to just a lichenoid or band-like infiltrate. Mycosis fungoides in general doesn't have epidermal changes, so you have lymphocytes going into the epidermis for no reason. With lichenoid dermatitis, they're there because they're attacking the epidermis. With eczema, sometimes they just go up, I don't know why they go there, but sometimes you have the spongiosis and you have some exocytosis. With mycosis fungoides, they're in the epidermis, again, sort of for no reason. So you have exocytosis out of proportion to spongiosis. In contrast to eczema here, and then the lichenoid tissue reaction of a lichenoid dermatitis down below. Here's the example again, a lot of spongiosis with exocytosis, not too much spongiosis, lymphocytes sort of at the base and within the epidermis. Sometimes you can have atypia with some of the non-mycosis fungoides cases, but it really still does help to sort of look at the cells and decide if they're atypical. So here, of course, I give you the best example I can find, but all the lymphocytes are darker, round. Maybe some of them are the size of the keratinocyte nucleus. And here, a lot of them are very small, even though there's a lot of exocytosis. There's also a lot of spongiosis, and most of these are small and smooth and round. But here's an example of allergic contact dermatitis, where you can see that we have these cerebriform, notched, irregular, enlarged nuclei, lymphocytes, but you also have an admixture of small, round, smooth ones. Sometimes they can be a little stretched. And so even though you have a few, it's not the majority of the lymphocytes. So this is also what I look for to see if most of the cells in the epidermis are malignant appearing. I mentioned the perinuclear halos and the lymphocyte in every hole. For some reason, there's a little artifactual clearing around the nucleus, and so this is also very helpful when we're trying to decide if something is lymphoma or not. The pattern of the involvement of the epidermis, again, the type of epidermotropism is helpful. I really pay a lot of attention to the base of the epidermis here, where they're peppering the base. Sometimes it's really obvious, but sometimes it's just a little bit of the beading at the base of the epidermis. The patria microabscess also is classic, as I told you. And you have to be careful not to get that confused with a Langerhans cell microabscess, because that is something you can see in a reactive eczematous process. They're a little higher. The cytoplasm is bulkier, sort of a light pinkish color. They have what we call reniform or bean-shaped or kidney-shaped nucleus that's smooth and not notched and hyperchromatic. And again, they're at the top of the epidermis. Sometimes they exit like a little flask. The pattern of dermal inflammation, infiltration by the lymphocytes is also important to look at. I mentioned the epidermotropic pattern, either within the dermal papillae or band-like without a lot of involvement of the vascular plexus, as you can see here in a case of, I think, lymphomatoid papulosis. Again, it stays pretty clear here and not involving the vascular plexus deeper down. Sometimes I can see vascular plexus involvement, but if I do see that, that makes me cut deeper to see if there's a hair follicle that's involved, because sometimes it'll involve the deeper dermis in that situation. Just another example of this pattern of lichenoid infiltrate up here, and then the sort of skinny reedy that we can see in mycosis fungoides versus, again, pityriasis lichenoides, which likes the vessels. And as I mentioned, the dermal changes are important. The fibroplasia that you can see is sometimes the only clue you'll have. Let's say they've been treating them with topical steroid and you treat the epidermal lymphocytes, then you're still left with some fibroplasia. So that can be a big clue to the diagnosis. With eczema and contact dermatitis, you do get some fibrosis, but it tends to be the lichen simplex chronicus, sort of chronic rubbing fibrosis. So we say it looks like fettuccine because you get these thickened collagen bundles here. You eat fettuccine here? You guys don't do pasta. That's Italy. You do pasta, yeah. Everybody does pasta. All right, so more fettuccine here. With lichen simplex chronicus, you start to get the fibrosis up and down. And then sometimes you'll have edema as opposed to fibrosis in the benign conditions. Now, we still do immunophenotype, even though we can think it probably is mycosis fungoides. It helps us to decide sometimes the treatment, but also help to confirm. And so, as I mentioned before, mycosis fungoides is CD4 positive lymphoma. So we look at the atypical cells and see if they have more CD4 expression than CD8 expression. And you can see here that all the bad guys are CD4 positive and are negative for CD8. In the dermis, it may be different because you'll have a reactive infiltrate there. So the other thing is you can lose some of these normal markers. So T cell markers also include CD5, CD7, and sometimes those are lost. and their expression. And so that can also help us decide if it's a lymphoma. CD7 can be lost even with benign dermatoses, but if it's like completely wiped out, that's also a clue for us. So here's CD3, CD4, that's sort of our template, and we see where the bad guys are. CD8, hardly anything, and also this is lost CD5 and CD7. So CD7 is not as specific, but if you have loss of CD5, that's also very, very critical. All right, so I'm just going to show you some examples of mycosis fungoides or not. So here is, it's either buttock or thighs, but you can see these. Can you guys see the scaly lesions here? All right. So here's a biopsy. The lymphocytes are larger. They're going in the epidermis. There might be some fibrosis here. If we look closer, you can see they're irregular here. You've got some irregular stuff, something here. I'm not going to say what it is. See if you guys can decide. So how many people think this is mycosis fungoides? How many think it could be mycosis fungoides? It could be. I showed you the atypical cells. The one thing that I didn't really highlight, it does have some dyskeratosis. It does have some holes without lymphocytes in it. So there is a touch of an interface reaction. So here's another lesion. You can see she's got a dry patch here, but then this one's a little bit more red, pink. So she's got some maybe older lesions and maybe some newer lesions. So, and here's another. You've got that guy there and then that one. So what diagnosis is this? Does anyone know? So this is pityriasis lichenoides. So with pityriasis lichenoides, you get small little, could be MF lesions, but they're little babies. And then they always go away. It takes a while, but they will go away with time for this diagnosis. But it can have some overlap with mycosis fungoides. So that's a chronic version of Mucha-Habermann pleva. Okay, it's sort of the chronic version of it. So pityriasis lichenoides chronica, a little bit more vascular involvement, more interface, but you can have the atypia, but the diagnosis is made clinically. So I showed you the atypical cells here, but the clues might be some interface reaction. Pityriasis lichenoides is the one that does like the vascular plexus. You can have some scale crust, interface reaction, red blood cell extravasation, and again, more vascular plexus than MF here. So the thing is, so pityriasis lichenoides is 100% benign. Well, 100%. It's maybe a cousin a little bit, a distant cousin of mycosis fungoides, because some of these patients can develop mycosis fungoides, or some people with mycosis fungoides can develop pityriasis lichenoides. And so it is somehow related. We can refer to it sometimes as a T-cell dyscrasia. There's something a little bit wrong with the lymphocytes because they can be clonal. So if you have a biopsy, or let's say you have a patient with what you think are pityriasis lichenoides, and you take a biopsy and you say, pityriasis rosea, pityriasis lichenoides, guttate psoriasis, that's your choice. And then you get a diagnosis of this could be mycosis fungoides. Now you know, well, maybe it's pityriasis lichenoides, but let me just check for a clone. You can't do that because pityriasis lichenoides will also be clonal. All right, so there's some little relationship with that. As long as it keeps going away, you can consider it to be pityriasis lichenoides. And so you can progress. This is an example of a 15-year-old who was diagnosed with pityriasis lichenoides, but he'd also had a bunch of patches that turned out to be CD8 positive mycosis fungoides in the past. So you see typical PL and then some chronic larger patches that are consistent with mycosis fungoides. This is another person who had pityriasis lichenoides lesions and also developed patches. So it's not common at all, but I've seen it maybe 3 or 4 times. So it can occur. All right, here's another one. Some dermis looks a little bit fibrose there. Maybe some lymphocytes here. A little close up. So how many think that this could be mycosis fungoides? We'll make it easier for you. Could be, maybe not. Okay, not. Okay, good. I agree it's not. So This is actually lichen sclerosis. So lichen sclerosis has been a known mimicker of mycosis fungoides. Sometimes it looks a lot like mycosis fungoides, but sometimes the one I gave you was not so hard. But just be aware that it can mimic mycosis fungoides. There's another case. I got a call from the oncologist to have me look at a biopsy, and he wanted to see if I thought it was lymphoma. So here's a biopsy, band of lymphocytes, so that could be mycosis fungoides. You can see the lymphocytes are also involving the epidermis. The epidermis has a little bit of spongiosis, but you can see there's almost a little patria microabscess there. So these collections of cerebriform lymphocytes, some collagen change in the papillary dermis. Here's CD3 highlighting lymphocytes in the epidermis and dermis, even some beading. CD4 and CD8 show a slight increase in CD4. I don't know that to me it would be diagnostic, but there is a skewing a little bit of CD4. It had a T cell clone, so it was a clonal infiltrate. So based on this, how many think that this is mycosis fungoides? I think it looks like it could be mycosis fungoides, to be honest. It turns out this was a foreskin that was removed from a guy, and he had some subclinical lichen sclerosis. But it was called mycosis fungoides, and then he went to the oncologist, and the oncologist said, I've never seen this on the penis. And so this is one of the pitfalls, is that it can really look like mycosis fungoides. But again, so these are things I'm sort of sharing with you as clinicians, just in case, because it's hard for us. I could have done that. You know, if I didn't know it was foreskin, I could have done the same thing. I think it can be really hard. All right, here's a very subtle one. Can you guys see the clinical change here? It's very subtle. I think mycosis fungoides, if that's what it is, can be difficult. It looks sort of just like dry skin. So here's the pathology. Do we have any clues? We got some skinny, reedy stuff going on. Maybe this is not quite as compact. Maybe some fibrosis. Maybe some lymphocytes in here. Based on this, how many think it is mycosis fungoides? I think it's tough. It's a little subtle. Here's CD3. So you can see how CD3 makes these beading guys sort of pop out. And so it can be subtle. Her clinical is also subtle. So this is an example where you sort of really need the two together. And here, usually if it's going to be mycosis fungoides, the epidermis will be much more CD4 than CD8. But I think CD8 probably is staining more of the atypical cells. And CD1A, which stains Langerhans cells, can also be CD4 positive. So that can mess up your assessment. So this one had marked loss of CD7. So that was another clue. And so she probably putting everything together, which is what we have to do, is she's probably mycosis fungoides. The immunophenotype wasn't classic, but she has more CD8 staining. So she could be either double CD8 and CD4 positive mycosis fungoides, or just a CD8. So without realizing and paying close attention to the immunophenotype and without putting it together with the clinical, it would be more difficult. So that's, again, it's a team, the pathologist and the clinician. Here's another example. We have sort of a dry patch on a guy. They wonder about nummular dermatitis. So here you can see it's showing some of the findings I think are a little suspicious. The lymphocytes are sort of patchy to band-like, hugging here. It has this funny reedy pattern being skinny, and then a lot of times it'll be sort of flat. So that's at low power, to me, sort of an MF-like immunophenotype. Here you can see here a little closer. There might be some vacuolar change, though, so it's not completely diagnostic. And you have some erythrocyte extravasation. So pigmented purpura can also have lymphocytes up at the top and have erythrocyte extravasation. And so just looking at this, I would wonder about lichenoid pigmented purpura. You guys see that here? PPD? Yeah, okay. So the question is this PPD or not? There is some hemosiderin that you can see here. So how many think MF? It's a tricky one. It could be MF or it could be pigmented purpura. The site was a little bit abnormal for pigmented purpura. Usually that's confined to the legs. Here, I showed you another area here where these are little hyperchromatic, they're a little larger, and then they have some perinuclear halos, maybe some fibrosis here. You can see here, they're lining up, they're sort of beating, they're very dark. So this alone, I think, would be very suspicious for mycosis fungoides. I'm looking here, very, very notched, hyperchromatic, all with these halos. So it's a dermal papillae cut a little bit sideways, so it looks a little bit weird, but it's still concerning. So here's CD4, CD8, and CD3. They look about equal, right? Now, the thing is, if you look closely, which is 3? CD3, remember that pops out all the atypical epidermotropic cells, and you can't really see them very well with CD4, but you can see them very, very well with CD8. So can you see that? So a lot of times people make the mistake and they just look at it, they say, oh, it's all equal, it's not mycosis fungoides, but you really have to pay attention to the abnormal cells and where they are. This person also lost CD5 and had almost no CD7. So other clues here, again, look at the atypical cells. That's the population that we like to pay attention to. And this is a close view of that. And CD1A can also be positive. CD4 can also stain the Langerhans cells, which are, I use CD1A to help sort of readjust what I'm seeing for the CD4. So helpful features on this one, this was a PPD MF or MF that had some PPD histology. And, you know, this highlights some of the things that I pointed out here, especially the loss of the antigen expression. What time is it? This is just, I'll just go quickly. This is another one, sort of band-like. This one has some Langerhans cell microabscesses, which, as I told you, was something that we see in reactive eczematous and allergic contact dermatitis. But other areas had hyperchromatic, really atypical lymphocytes here, jagged and large. You can't really tell, but has the cerebriform nucleus. And here's CD3 showing exocytosis. And CD8, CD5, they really don't have as much positivity in the epidermis, so it has some abnormal immunophenotype. But to be honest, it was not completely diagnostic to me. It had the Langerhans cell stuff. He'd been treated as chronic atopic dermatitis. They thought it was a lot of post-inflammatory pigment. And so I sent 2 different biopsies for PCR. Do you guys do PCR here? Yeah. And now PCR, the way it's typically done is not quite as sensitive and specific, but overall, if you have the same peak, the same clone that they diagnose in 2 different sites, that has shown to be much more diagnostic of mycosis fungoides than just one random one. So I'll use that a lot and to help me decide if something's mycosis fungoides. And so it turns out he really has total body involvement, and he has the hyperpigmented variant of mycosis fungoides. So they were thinking it was probably just post-inflammatory pigment, but it's just the type of mycosis fungoides that he had. But putting everything together was how we were able to make the diagnosis. So here's another case. You guys see hyperkeratotic eczema here? Everybody has that, unfortunately. So you can see cracked hands, took a biopsy there. Some maybe non-specific stuff there. Also on his feet, he had the same thing, a biopsy showing some spongiotic dermatitis. Would you guys agree that's your typical dyshydrotic eczema type change? Okay. Here's another example here. I sort of took note of that little guy there. I can't believe he has a shaved body. Oh, no, I told him to take a punch. The first time he did a shave, I told him to take a punch because I wanted to see that structure there. But here's your very, very spongiotic epidermis with a Langerhans cell microabscess, classic sponge derm. Could this be MF? I'm talking to you, so yeah, of course it could be. So I wear these special glasses when I'm signing out if it's something that I really have to decide if it's mycosis fungoides or not. And while it does have that sort of lichenoid hugging infiltrate, I also was concerned about that down there. Here you can see the top is spongiotic, but then starting to get some of that skinny, reedy pattern as opposed to the broad acanthosis. It had some epidermal change here, but again, I like to look at the base of the epidermis, and almost every single one, I don't know if you can tell from the back, but they're all notched and not nice and round, and plus they're just all living at the base. So to me, that's very abnormal. Here's another area where all just notched and irregular at the base of the epidermis, more of them here. You don't even need the glasses to see them now, right? Sort of hugging the epidermis as opposed to the later the lower vascular plexus that we see in eczema. And it turns out that he actually had mycosis fungoides. He had syringotropic mycosis fungoides. He had matching clone in, so here's the deeper eccrine coil with lymphocytes not only around it but in it. And he had that in his hand and his foot, and also he had a patch on his thigh. So I had him take biopsies of all of them, and they had matching clone. One was sort of a baby clone, but looking at it and putting it all together, they thought it was all the same. So sometimes we have to work really hard to put everything together. This one surprised me. I think I was lucky to happen to see the eccrine coil there. So those are just some examples of how ClinPath correlation, using immunophenotype, using molecular ways that we can get to the diagnosis. Just to say a few things about drug-induced pseudolymphoma or reactive lymphocytic infiltrates, you can have a drug cause all sorts of lymphoma type reactions. It can be a tumor that could simulate a B-cell lymphoma or a bulky T-cell lymphoma. It can look like mycosis fungoides. You can have a drug look like pigmented purpura type mycosis fungoides. I mentioned CD30 reactive infiltrates that can look like lymphomatoid papulosis. And I've even seen that after a COVID vaccine. I've seen some lymphomatoid papulosis either induced by it or sort of pseudo lymphoma. So here's an example of a drug eruption, very, very like a lot of lymphocytes in the epidermis, but they're small. There are holes without lymphocytes, so they're not necessarily haloed, a lot of spongiosis. You know, the papillary dermis does not look that fibrotic. Even though you have some lymphocytes at the base of the epidermis, they're not only there. It's just sort of all over the place. Here again, some lymphocytes at the base, but they're probably involved in an interface reaction because you also have some vacuoles here. And also, again, the edema is going to help you as opposed to the fibrosis. The immunophenotype is going to be, not too heavy on the CD4 versus CD8. They're going to be barely increased, which is normal. CD7 may not be lost. So you can use these to decide if it's drug. Sometimes it's still very difficult to differentiate. All sorts of drugs can cause a pseudolymphomatous reaction, especially the antidepressants, the statins, the anxiolytics, the anti-seizure drugs, biologics. So pretty much if your pathologist said could be mycosis fungoides but exclude a drug, you might get, they're probably going to be on one of these, but it's not like a drug hypersensitivity reaction. They're taking the drug and it's altering their T cells, which takes a while. So it might be a drug they started a few months before or several weeks before, and not one they just started. And then also when you stop it, it's going to maybe take a while to have the rash clear up, but it should clear up in, a few weeks. I don't know if you can see this. So this is a patient who is on dupilumab. You guys use that here? Okay, yeah. It's a great drug. I don't have any, unfortunately, financial relationships to the drug company. But this patient was on dupilumab and was doing fine, and then they started getting new lesions. And so it's sort of in the thigh groin area here. And here's the biopsy. I think it's a little heavy up here. It is around the vessels too. And on high power, I thought a lot of these were actually very atypical. I could see, true MF looking cells here. So I was concerned that this might be a problem. And so you can see it's very skewed towards CD4. And so I called the clinician and told her that, they might be having a switch over to mycosis fungoides with dupilumab. The patient really, really, really wanted to keep on the medicine, so they're just going to watch carefully. But what do we do in this situation? So dupilumab has been shown to cause lymphoid reactions. So it's not going to always cause lymphoma, but lymphoma is a thing we worry about with some of these patients. So this group looked at patients. They did find 3 that when they, so these are patients they saw that where they were concerned about lymphoma. They found that 3 of them actually probably had lymphoma to begin with and not atopic dermatitis, which is not uncommon because it's a hard diagnosis to make, as you guys now know and already knew. They found that it was around 4 months of taking the medicines, at least this study showed, and they were able to show clearance of all the rash, even though they had atypia with stopping the med. So they were able to show that this is a lymphoid reaction and not lymphoma. But you guys have heard that there can be a problem with lymphoma and dupilumab. Have you guys heard of that? Yeah. Yeah, you discussed it already. Oh my gosh, you guys can tell me about it because I haven't had the update. But did they talk about the pathology? No. Okay, yeah, good. So, well, it's going to be hard to diagnose because it can look like lymphoma here. It's got some spongiosis, not a lot of exocytosis, so it's not that bad. But you can see here there can be marked CD4 skewing. You can also have some CD30 expression in these cases. They didn't tend to lose the other markers like CD5. So there are a few things you can look for to decide, by underneath the microscope, if you take a biopsy, that it may or may not. But to be honest, if I had atypia, stuff like this, I would just stop it and see how they did and go from there. So those are the lymphoid reactions. But then there are also, as you know now, or knew anyway, that you can have true lymphoma arising in patients who are on dupilumab. Some of these patients had CTCL and were on it for itching, and they actually got much worse, and some of them died. And then you had some that had atopic dermatitis that did develop CTCL. So you do have to be careful with this. Some clues are, areas that didn't used to be involved by their eczema, now they have involvement. Lymphadenopathy, obviously, a lot of itching where, it's supposed to help with the itch. So there's going to be a change in the pattern of their presentation. We're just going to skip this. Yeah, just to stress that people did die, so you have to be careful with that. And it can be all sorts of, it can be erythroderma, it can be palmar-plantar change, it can be patches, plaques. It tends to be more sort of the advanced MF in some of these patients, or advanced CTCL. You guys use MOGA here? Did you already hear about this too? But not the pathology? Okay. So, so as you know, so patients who are treated with mogamulizumab will have a rash. A good portion of these patients have a rash. And the rash is actually good. It says they're responding. So you guys know all that now. And, they make a big deal about the rash and how it can look like mycosis fungoides. But to me, it doesn't look that much like mycosis fungoides. But anytime you are treating somebody with advanced disease and they get new lesions, you're going to biopsy, be concerned. And this can have a variety of different clinical presentations and a variety of histopathologic presentations. It can look like MF. It can look psoriasiform. The clinical lesions can be sort of photoaccentuated, like the head and neck. But there, at least in one study, they showed 4 different types of reactions. It could look like folliculotropic MF-like, it can be granulomatous, it can have an interface reaction, or it can have sort of psoriasiform and spongiotic reaction. It's helpful to do CD4 and CD8 because that won't be that abnormal. And in fact, in the photo-accentuated presentation, it can be switched, almost like an actinic reticuloid. They don't lose CD7, which is a typical MF thing. And if you check for clonality, it'll be polyclonal. So one, underneath the microscope, it doesn't look that MF-like, and it's, doesn't have that many abnormal immunophenotype, and it's non-clonal. So that one's, I think, pretty easy. It's not like dupilumab. It's pretty easy to help differentiate. But as long as you guys know about it. And for pathology, it can look like all different types of changes, as I mentioned. Here's just some examples, sometimes a granulomatous reaction with it too. And here are just some clinical examples, which probably you guys already saw pictures of. My husband isn't in the room, is he? These are like real-time shots. So I figured you guys might be tired by now. You guys still okay? Yes. You still with me? All right. So now I'm going to go over some variants. So a lot of times, I'll say in the old days, mycosis fungoides was missed because people weren't aware of variants. And so, of course, you know, it's not this because mycosis fungoides doesn't do that. So I'll just go over some of the variants. Hypopigmented, it can look like pityriasis alba. I don't know if here you see it as much. It can also seem like vitiligo and sarcoid. Palmar plantar is its own sort of subtype. Syringotropic, pigmented purpura, I told you about those. There's also a papular variant. The hypopigmented mycosis fungoides type tends to be CD8 instead of CD4. Most pathologists know that now. Before, if we required the CD4 increase, then that would have us say no, but now we know this is CD8 positive. It can be very, very subtle. Sometimes the lymphocytes are very small, and in fact, some people have advocated not calling it lymphoma, of calling it some sort of interface T-cell dyscrasia or something. But, you know, they've got it all over. You might as well treat them like a lymphoma so that they can get some light and some therapy. So that's one variant. The syringotropic type, these sort of brownish red macules starting on the acral skin. It can go all over. Sometimes it can be very subtle, and you can just barely see it. And sometimes, you know, people where I am, they all like shave biopsies. But if you take a shave biopsy, you're going to miss the diagnosis. So subtle, but if you see that little tiny little, these little guys here, just take a little punch there. Pigmented purpura, I already showed you an example. So pigmented purpuric MF can look just like regular pigmented purpura, but it tends to be more widespread, abdomen, upper thighs, buttock. I don't know, sometimes I don't know when to call it and when not to call it, because sometimes it won't be as diagnostic under the microscope, but it's all over. So sometimes I'll call it atypical pigmented purpura. You know, I'll try to do clones and stuff like that. But on your end, what do you do? If you have a, you know, classic pigmented purpura and it's everywhere on the bud and everything like that, and it's called pigmented purpura without stains, you might ask your pathologist to maybe, could this be pigmented purpuric MF? And, you know, try to push a little more. Because it can look very much the same. I mean, if we, to make the diagnosis, we do all the things, try to confirm mycosis fungoides in all the ways we usually do it. Cytology is bad, immunophenotype is bad, and clonal. So that's just sort of how we have to do it sometimes. Oh, I thought we fixed that, but I guess not. Okay. Here they looked at some cases with pigmented purpuric MF and compared, and it's sort of the usual, more generalized, persistent, abnormal immunophenotypes. So all the sort of, you just have to try harder to confirm it's MF to be able to call it that. The patient I had like a billion years ago who had papular MF, which I thought was quite interesting. There have only been a few reports in literature, not including this one. I didn't put this one in the literature, but I like to tell people that this is one of the variants. It would be hard for anybody to call it that because it's little baby histologies of MF. I think to get this diagnosis, you have to do clones in 2 places. But this is all just FYI, you can see this. There are histologic variants. This is a patient with lichenoid mycosis fungoides, like totally wiped out. Interface, colloid bodies, like there's no way a person could call that mycosis fungoides unless you had the clinical. So I had her clinical to go with it. And so it can be a tough one. I sort of went through some of the findings, ways to differentiate the two. We're going to skip that. And then I think looking for these atypical cells is going to be very helpful. Here it's very subtly lichenoid. It can be tough, I think. In fact, the group at Yale looked at some cases of mycosis fungoides that were missed because they had an interface reaction. So they went back to see, you know, how could we not mess up the next time? And so they found that the beating of the lymphocytes at the base of the epidermis, fibroplasia, and atypia of the lymphocytes, all these things I've been pointing out to you guys, those are some of the features that help them. Sometimes lupus can interface, can have similar changes, and CD123 has been found to show clusters of plasmacytoid dendritic cells in lupus and not in mycosis fungoides. So they showed that also their cases did not have CD123 positivity. And I thought it was a really nice articles. They showed the earlier non-diagnostic ones. My lymphoma glasses have almost become contact lenses because I keep them in all the time, but I can see here some beading. But this is a long time ago when probably they didn't realize. And then this actually has a true lichenoid interface reaction, and then it became more diagnostic. So they had their early ones, some fibroplasia as a clue, and then, you know, as the lymphocytic infiltrate became heavier, and of course the patient is not responding appropriately, you get all these clues as to why it's not an interface reaction anymore. So they had the clues that I mentioned, fibroplasia, the halos of the lymphocytes, absent 123 staining. All right, here, I guess I have a half an hour. It's so good. So here's a biopsy from the chest. Dense infiltrate, a lot of atypia here. How many think this is MF? How many think it could be MF? It could be MF because they're very atypical. Now, biopsy from the chest, I didn't give you any other history, but there's a little bit of a solar lentigo beside it. So this is a lichenoid reaction to a solar lentigo or a lichenoid keratosis. Do you guys get these here? Okay. But it can have a lot of atypia. So back a long time ago when I started signing out lymphoma, I would get these as consults before people realized. So if you have something, you shave it off and you say, rule out basal cell carcinoma versus what eczema, and it comes back as lymphoma, you have to think, could this have been a lichenoid keratosis? Some people also refer to something called a lymphomatoid keratosis, because sometimes these can look very, very atypical. Here's another one. You got that. Peppering of lymphocytes in the base of the epidermis, some atypia within the epidermis, also a lichenoid tissue reaction blurring the junction. I think there is some atypia here, but there's also the dyskeratosis. Again, more atypia. Here's the immunophenotype. CD4, much higher than CD8. Could this be lichenoid mycosis fungoides? I think it could be. Again, the lichenoid tissue reaction's tough. And so what else can we do? Well, I didn't see the patient, but I got the history, and the patient had another biopsy in the past, and they thought it was maybe lichen sclerosis or something. It sounded like it was a little dry patch, maybe a little hypopigmented, and then that biopsy was suspicious for mycosis fungoides, despite being sort of like a nothing burger, had almost nothing clinically. And so I got that biopsy, and here's that biopsy here. And you can see it's got compaction of the stratum corneum, it's got lymphocytes hanging out around the base of the epidermis, and a lot of them are jagged, they're perinuclear halos. And so this one I thought was mycosis fungoides. So sometimes you have to do a lot more work, either take another biopsy or find out if there's been another biopsy somewhere else, put the two together. You know, if your differential is eczema versus mycosis fungoides, this is just not eczema. If it's drug-induced mycosis fungoides versus mycosis fungoides, that's a little trickier. But if you get more than one biopsy with a lot of atypia, abnormal skewing of the immunophenotype, at some point, especially if you can get dual matching clones, at some point you just have to call it, as long as they're not on medication. So recently a group showed some cases of spongiotic mycosis fungoides. Here are just different ways they presented with a little bit of spongiosis. Just a little, I guess. But they found that these patients had previous diagnosis all across the board, a lot of different types of reactions, even blisters, but they weren't responding to steroids like you should for eczema. Eventually, they were diagnosed with mycosis fungoides. So spongiotic dermatitis can, even though spongiosis is not supposed to be a feature of mycosis fungoides, sometimes it can be very prominent. So many years ago, I collected some patients with mycosis fungoides, classic mycosis fungoides, dry patches on the butt, upper arm, and then more of a plaque on the leg. And her plaque had tons of spongiosis, like totally spongiotic dermatitis here. But it also had a lot of CD30 staining. And the lymphocytes, even though it's very spongiotic, were very, very epidermotropic. So it's just peppering the epidermis. So even though there's a lot of spongiosis, if I sort of take that away, I can still see that there are a lot of lymphocytes in the epidermis. You can still use the perinuclear halo thing to make the diagnosis. But I mean, overall, I think spongiotic dermatitis is tough to differentiate from mycosis fungoides. Sorry, spongiotic mycosis fungoides is hard to diagnose from regular eczema. So this is one I'm not even going to ask you. So this is very spongiotic. I think they'd fire me if I tried to call this mycosis fungoides. But if it's submitted as, rule out mycosis fungoides, of course I'm going to look. So clinically, it's a papule with a background of sort of an acneiform eruption. So knowing it was a papule, when you take a punch biopsy, your bulk of it's going to be in the center. So, it's our job to just keep cutting till we get the middle of it, where more of the findings are going to be. And so in the middle, a hair follicle pops up with some follicular mucinosis, lymphocytes around and in it with marked CD4 skewing. So this person actually had folliculotropic mycosis fungoides. In this particular case of spongiosis, the CD4, CD8 ratio is very helpful because there's almost, have you guys ever seen a CD8 positive folliculotropic mycosis fungoides? I've just never seen one. You saw one, all right. Was it really that? No, yeah, so it's very rare. So I find that skewing of 4 is very helpful. So in general, the spongiotic mycosis fungoides is very rare, but where I've seen it has been in the folliculotropic type. And it's confusing also because you can have a lot of eosinophils with that as well. And plus they're itchy and it's not on the double covered site. So the clinician, y'all aren't really aware that that might be what the diagnosis is. Here's just another example of that. Very, very spongiotic, tons of eosinophils, but marked CD4 over CD8, really peppering, lining up around the edge of the hair follicle. And this person, it looks like, to be honest, this is one I didn't read. I stained it afterwards because I got a later biopsy of his, so I wanted to learn from it. Very, very spongiotic. And turns out I saw him at this stage. So the diagnosis was missed because, for obvious reasons, because it didn't look like mycosis fungoides. It was very spongiotic. But fortunately, he came back and they re-biopsied, and he, he had full-blown mycosis fungoides. The hyperkeratotic eczema situation, I find that can look like mycosis fungoides a lot. And again, the Yale group, I love those guys. They do a lot of nice work. And so they looked at some of the cases, and they found that the clustering of the little microvesicles, almost like a dyshydrotic change, is helpful. And the Langerhans cell microgranulomas, they also find were helpful. But as I showed you, you can have that in mycosis fungoides. So these are the things that they found helpful. But you can see, so this is an example of hyperkeratotic palmar erythroderma, palmar plantar erythroderma. You can see how many lymphocytes are here. They can stuff the dermal papillae. So there's a lot of overlap with mycosis fungoides. This is just FYI. There's an interstitial variant of mycosis fungoides that I'm probably going to miss if I haven't already missed it. I've seen it a couple times. But if you get a clinical presentation that you really think is mycosis fungoides, and we call it interstitial granuloma annulare, take another biopsy because that could be interstitial mycosis fungoides. I think it's hard to diagnose it. Folliculotropic mycosis fungoides, I've mentioned a lot of different presentations. It can be acneiform, you can have hair loss, you can have tumors, you can have these spiky little follicular spines. It tends to be very itchy, and the diagnosis is made by looking for folliculotropic and folliculocentric lymphocytic infiltrate. You might have follicular mucinosis. Here, you wouldn't even know that was mycosis fungoides. It's itchy and it just looks like he's got eczema, but he's missing his hair here. He's got hair here, but none here. So sometimes it can be very subtle. Here are tiny little papules, very, very subtle. It's not your classic presentation of patch stage mycosis fungoides. Here it's a little bit more advanced. She's lost all her eyebrow hair. It's almost becoming leonine here a bit. And sometimes it can be very, very dense, plus have eosinophils, plus the hair follicle can pop and you can have a granulomatous reaction. So there are a lot of pitfalls on our end to making the diagnosis of this. So again, we have to sort of put the story together, clin path correlation with this. Sometimes it can be very acneiform. You know, I don't know what to tell you. I think it's more of a plaque, even though it's sort of acneiform, she's starting to develop a plaque. And if you start to see loss of eyebrow hairs, you know, look in other areas if there's hair loss, and you have to wonder about this diagnosis. It helps to submit 2 for clones, again, to see if you have matching clones. I think showing that it's a CD4 rich infiltrate from a pathology point of view is also helpful. All right, here's a case. Red abdomen, arms okay, lower part of the back's a little red. So he's a guy who had an MI and was put on some MI meds. He lived till 90, still, is he still, I don't know if he's not alive anymore. But at 90 he had an MI and got put on some meds, so they thought it was probably a drug rash. And so, I'll show you the biopsy, sort of perivascular infiltrate. Not much change in the epidermis, not really any epidermal involvement, mostly around the vessels, some eosinophils. Okay, there's one there. So based on that, who thinks he might have mycosis fungoides? Or let's say, who thinks he could have CTCL? Again, I'm up here, so he could. But he might. But like, it doesn't seem like he would, because he doesn't have any epidermotropism. He's not erythrodermic. He had some drugs, so it makes more sense that he's probably got drug rash, but you just never know. So turns out he was very CD4 rich, almost no CD8, most of his lymphocytes were PD-1 positive. So he had marked skewing towards CD4, and on close inspection, a lot of these are cerebriform, most of them. And so on his biopsy, I told him I thought he might have Sézary syndrome, so they got clonality studies. And he really had full-blown Sézary with very high CD4-CD8 ratio of his lymphocytes, very high CD4 positive, CD26 negative. These are all the things that we look for. And just overall, his abnormal T cell count were well over 1,000. So he's full-blown Sézary syndrome, B2 blood involvement. But he didn't have erythroderma. So usually with Sézary syndrome, as you know, you get erythroderma, you get palmar-plantar keratoderma, you start getting your eyelids pulled down from just the tumor stuff there. But a lot of times a biopsy will not be diagnostic. In fact, it's usually perivascular. Sometimes you can even have spongiotic change or psoriasiform change on the top. So you have to do flow cytometry. So you all know about Sézary, right? You probably don't see it that often. All the people that I work with, they keep forgetting that you can't get the diagnosis on the skin. Everybody forgets that. But probably you all know, because she is the queen of Sézary. She's written all the beautiful papers, you know. Here, oh yeah, here you can see when I wear my special glasses. So this is taken from the microscope. The other one was taken from the digital image. We're all gonna go digital, but it's gonna like hurt the lymphoma people because we can't see what we need to see. So this diagnosis you make by blood. You can go ahead and take the biopsy. In fact, it might help because you can take the biopsy and send send it for clonality, because you want to match the blood and the skin clone to make sure it's a relevant clone, because some older people can have a positive clone that's not malignant. But you look for the abnormal immunophenotype that I showed you. You know, there are percentages that are out there. Julia has, are you still promoting the 250 thing? Yeah, so she's promoting just looking at the absolute numbers of these. You've got this in-between zone, so B0, you probably don't have it, but some of those people might eventually progress, not everybody. You've got the B1 that's sort of not full-blown Sézary, but not totally normal. Some of those will progress. And then you have the full-blown Sézary. And so this guy also didn't have erythroderma. So there are some cases where they're not erythrodermic, and that can be a problem. One of the clues is that they're very itchy. And so, you know, you could have MFE stuff, almost nothing, just itching. And so this is just another example where they didn't have that many, where a lot of these patients never progressed to erythroderma. And so for flow cytometry, obviously you get it if you have an erythrodermic patient, but it's also important to get it to see if you have a lot of patch plaque disease, if you're starting to get involvement of your peripheral blood. And then also as a diagnostic measure, just like pruritus, sometimes we'll get a biopsy to rule out pemphigoid, right, for DIF. You might even consider doing clonality if they've got like total, itching for no reason, just like as a part of your workup. We sort of have a long way to go, but I think I'll be all right. Okay, I won't even ask you anymore. Yes, this could be mycosis fungoides, but it's more wedge-shaped, so that usually tells us it's a papule, and it's CD30 positive. So this is an example of lymphomatoid papulosis. Remember, this is the one, the lesions have to go away. They're usually small, under a centimeter, usually go away within about a month and a half. They progress through like little papule, they get crusty or necrotic, and then they sort of dry up and go away. And then you make the diagnosis based on the presence of CD30 positivity at various degrees with the clinical presentation. And I have these as an example because these are regional lymphomatoid papulosis. So if you don't know that that exists, you might, and I've seen this happen, just call it recurrent bug bites, because sometimes they're a little itchy. So you can have regional. A lot of times you'll have different phases of evolution with the papules. So there are different letters that our residents think that they have to learn, but I guess maybe they do now. But there's a classic lymphomatoid papulosis where you have the large CD30 cells admixed with neutrophils, eosinophils, and small lymphocytes. Sometimes this is, called bug bite or drug rash because of the mixture of EOs. Type B, you have a lot of little small lymphocytes that look like mycosis fungoides. And type C, you just have a wad of these atypical CD30 positive cells to the point that it can look like anaplastic large cell lymphoma, just sheets of them. So obviously there are pitfalls in the CD30 positive lymphoproliferative disorders because it might be hard to differentiate this from large cell transformation. Advanced mycosis fungoides can get big cells. Sometimes they're CD30 positive. Sometimes it's hard for us to differentiate that from large cell transformation. Inflammatory dermatosis, as I told you, can have CD30 positive staining. Like scabies, I've seen scabies called lymphomatoid papulosis because of CD30 positivity, and ruptured molluscum or herpes lesions, all those can look like CD30 positive lymphoma. So here's type 3, solid CD30 staining can look like anaplastic large cell lymphoma, except anaplastic large cell lymphoma is a larger tumor or plaque, can hit any age group. Usually, as I mentioned earlier, pretty indolent, but if you have a lot of these, especially on the leg, you might have a worse prognosis. And then underneath the microscope, the same sort of finding, only more of it. So involves the epidermis, a tumor, mixture sometimes of nus and eos. The thing about anaplastic large cell lymphoma is sometimes systemic lymphoma can go to the skin and look like anaplastic large cell lymphoma. It tends to be ALK positive. So when we get a tumor of anaplastic large cell lymphoma, we stain it for ALK. If it's positive, we say it might be secondary. A little caveat, you can have ALK negative anaplastic large cell lymphoma systemic going to the skin, so we can get fooled. Or you can have positive primary cutaneous anaplastic large cell lymphoma that's ALK positive. So just note that, but for the most part, ALK means systemic. There are other types of lymphomatoid papulosis that have always been there, but have now been recognized as these little subtypes. So there's type E, which is angiodestructive, and there's type D, which is very epidermotropic and cytotoxic and can look like the Berti lymphoma. So this is the example of type D, very epidermotropic, cytotoxic. Remember at the beginning I said cytotoxic can sometimes mean aggressive. And it'll be CD8 positive, which is a little unusual. And so, but the clinical looks like LYP. So if you have little papules, you say roll out bug bite or something, and I say we because we all can do this, and we call it, could be aggressive lymphoma. Just talk to whoever's reading the biopsy and have the conversation, could this be that? So type E, the destructive type, you can see that it's markedly atypical. This is all necrosis, and it follows the, it's elongated lymphocytic infiltrate because it follows the vascular plexus. And so the nasal type, the NK T cell type, gamma delta type can have this sort of destructive histology. But in this particular case, this patient had regional LYP that just kept coming and going and had this type E angiodestructive phenotype. So again, ClinPath correlation. Here's another one. I had multiple biopsies from this person little by little, and I was sort of thinking it was CTCL, very, very, very epidermotropic, also very, very CD30 positive. So I thought it was maybe anaplastic large cell lymphoma because they never gave me all of it. So I just called it CD30 positive, blah, blah, blah. And then they gave me more biopsies. And then it was negative for beta F1. Here, very positive for CD30, negative for beta F1, negative for CD4 and CD8, and very, very positive for gamma delta. So remember I said the gamma delta T cell is less common, and that can be associated with aggressive lymphomas. Well, this was, I thought maybe a gamma delta lymphoma, but it didn't make sense. And it turned, I asked them to give me pictures of the guy. It turns out he has lymphomatoid papulosis with gamma delta immunophenotype, which is not that common. There have been a few of these cases written up as a collective and showing that, you know, we see this type thing. And the patients did well. So again, another example of how you can have histology that looks scary, but the clinical makes it, you know, not so bad. So let me just go on to a couple more in the next. I have 10 minutes, go till 1:30? Okay. So just a quick differential of the very, very epidermotropic lymphocytes. So I already mentioned, well, obviously mycosis fungoides, but it's usually not that epidermotropic. There's a subtype called pagetoid reticulosis, which is very, very epidermotropic. Tends to be like a unilateral acral lesion that's indolent. There's the Barretti lymphoma, the aggressive epidermotropic CD8 positive one, where they just get progressive, like ulcerative nodular mucosal and skin lesions. And then gamma delta can sometimes be epidermotropic. And there's also lymphomatoid papulosis. I didn't mention the DUS22 one, but that's for another day. So the Barretti lymphoma, very, very epidermotropic and very adnexotropic. So it's hard to see. Yeah, so that's an equine duct. So it's like very, very syringotropic, plus very epidermotropic. It can be in the dermis, but also very epidermotropic where you have residual epidermis, because sometimes it gets necrotic. I want to sort of skip. Gamma delta lymphoma, as I mentioned, is usually very aggressive, necrotic, but there is a variant that's more mycosis fungoides-like, very epidermotropic. Some of those can progress to more aggressive gamma delta. It's due to a different subtype of the gamma delta T cell. I'm not going to go into that. Here's how it usually looks. Rapidly progressive, necrotic, because a lot of times it's angiodestructive, often in the fat as well as the dermis, and it's positive for the gamma delta T cell marker. Now we use TCR delta instead of gamma. So here's just an example of how it can be very, very epidermotropic. So if you have a patient with mycosis fungoides and we diagnose gamma delta lymphoma, there is this variant that's potentially a little bit more indolent, but you still have to watch them. Pityriasis lichenoides, Mucha-Habermann type, can sometimes have gamma delta immunophenotype. So can, as I mentioned, lymphomatoid papulosis. Getting into the subcutaneous infiltrates, SPTCL that I mentioned earlier, indolent. Usually, these are all cytotoxic lymphomas. It's cytotoxic, but it's indolent and alpha beta. Let me just go through these. Okay, so it's characterized by rimming of the adipocytes. That's very characteristic. It's really confined to the subcutaneous fat, and it is alpha beta positive, cytotoxic, and CD8 positive. In contrast, the gamma delta lymphoma is going to be CD8 negative. In fact, it's usually negative for CD8, CD4, and CD5. It's going to also be cytotoxic, but it's going to be positive for TCR delta or the gamma delta marker instead of the beta marker. So multiple negative markers on this one in the fat. Got to think of this diagnosis. It tends to involve the dermis as well as the fat in comparison to SBTCL. The one thing you need to know clinically is that SBTCL can be difficult to differentiate from lupus panniculitis, like really hard in the borderline lesions. Sometimes it can go one way, sometimes it can go the other way. We will look at Ki67 staining to see if it's staining the rimming adipocytes, but you guys don't care about this stuff because that's our job, and it's hard for us too. But just know that it can be a difficult diagnosis. If it's a question of lupus versus SBTCL, just watch them carefully. They'll probably declare themselves. All right, we're going to end shortly here. This is an example of a lesion that treated and responded as pyoderma gangrenosum. Looks like pyoderma gangrenosum. It's a little bit icky in the middle, so I don't usually call it that, but I can see how it was called that, and it responded like PG. But they had several biopsies over the course of the year that I saw, and it was not PG, and these had very, very syringotropic lymphocytes. So the eccrine ducts are just filled with lymphocytes within them. And he ended up having a very aggressive syringotropic cytotoxic lymphoma that was simulating pyoderma gangrenosum. So sometimes, this is another example in the literature, sometimes you can have an infection or PG or just an ulcer that is actually lymphoma. So it'll be important. I got one of these the other day and they gave me a shave biopsy. I said, go back again. You got to go deep, okay? So clues to the aggressive lymphoma is rapidly progressive, sometimes mucosal sites, crusting, nodular, and just remember that you can have the same histology for both aggressive and LYP. Now, I mentioned cytotoxic being bad. There are some situations in which cytotoxic does not mean bad. There's the acral ear one that I told you about, the acral CD8 positive lymphoma. It's going to be cytotoxic, CD8 positive, but it's clinically, you guys decide what the answer is. It's going to be slow growing. It has been downgraded from lymphoma to lymphoproliferative disorder for that reason. And here's just an example. Acral is not just ear, it's also finger, foot, hand. And again, even though it's cytotoxic and CD8 positive, doesn't mean it's aggressive. And similarly, this is the last one I'm going to do, the CD4 small medium T-cell lymphoproliferative disorder is a solitary lesion that seems like could be a bad lymphoma, but in fact, it's slow growing. You guys decide if it's aggressive or not. Usually it's biopsied, rule out BCC, rule out cyst, and we see an infiltrate. This one's hard for us to diagnose because we have to see that the CDA can be both look like it's about equal, but the atypical clusters of CD4 cells we can find as being PD-1 positive. Here's another example. It's a dermal tumor. You make the diagnosis of this by excluding background mycosis fungoides. A lot of times it has a lot of CD20 positivity also, which makes it hard for us. We look for these PD-1 clusters. And the problem is there are so many B cells sometimes, and sometimes it'll have a T cell clone and a B cell clone. And for a while, that used to confuse me, and I just decided, well, maybe there's some overlap. And then since then, there have been cases reported of overlap of small medium T cell lymphoproliferative disorder and marginal zone lymphoma. So both of those are benign in acting. They're usually solitary lesions. So if your pathologist can't make a decision on what to do and you get clonality and they both are clonal, it's usually going to be okay. Just continue to follow those people. And 1 minute summary, I sort of just I could regurgitate everything, or you just can remember what I said. But I gave you different clues to MF. I talked about variants, just be aware of. Diagnose Sézary on blood and not skin. Remember the aggressive ones. All the things I've been telling you about that. And I think that's just about it. Afaristo.
Thank you very much.
An excellent workshop and lecture. It was very, very educative, and I think we learned a lot. I don't know if there are any questions from the audience. Ναι, ο κύριος Κακέπης.
They're speechless.
There is one question.
Okay.
Congratulations for your nice talk. I would like to ask the incidence of lymphoma of people taking dupilumab for atopic dermatitis. Do we know any details about the incidence? What's the incidence of developing lymphoma under dupilumab for atopic dermatitis? Do you have any?
So the incidence of developing lymphoma from patients using atopic dermatitis.
Dupilumab.
I'm sorry, dupilumab.
Yeah.
I don't think the incidence has been. It's hard to capture the exact incidence, but I'll have to say it's rare. Okay, but it's going to be rare depending on how you choose your patients. So if you just put it on a whole bunch of patients and don't double check that they don't have lymphoma, you get up a higher incidence. But for the most part, in the literature, there have not been that many cases. I think there were maybe 24 reports that were reviewed, but it will be skewed in the literature. But overall, I think it's not common. I don't know if you guys can comment on it.
I agree completely. I think we discussed this in the morning, and it's exactly as you said. You have to be very careful with your diagnosis, and if you do the correct diagnosis, then you don't use dupilumab in CTCL.
Yeah.
So this is very important.
Thank you.
Yeah, and with regard to the development of lymphoma, what'll happen is they will get better, and then after about, I sort of went through the slide quickly, maybe average of 7 months, they'll start to either get worse again or more itchy or something that will trigger you to maybe take another biopsy. And under the microscope, what we'll tend to see is more of a lichenoid infiltrate. So it's doing something to the lymphocytes. It may not make it malignant, but what's been reported is more of a band of lymphocytes, so heavier, more band-like. And at that point, I would suggest to stop it. Your patient won't like that because they're going to love the medicine, and see if it gets better. And if it gets better, you could cautiously start it again. But I personally wonder if, with time, if you keep going, it's going to continue to alter the lymphocytes so that you're eventually going to have a problem. But the key is also to make sure they didn't have lymphoma before. But in some of the studies, they swear that it wasn't lymphoma at first. So apparently there are some atopic dermatitis patients who can still develop lymphoma. So it's a tricky thing. And your patients, I mean, we all want to help the patients. So, it's tricky, but just do it sort of smartly. But the incidence is not high right now. But again, I think people are cautiously using it. We're good? All
So
right.
I would like also to congratulate you on one more or less excellent presentations you are doing the last years. And I would like to say that you have dissolved the myth or the notion that exists among our fellow dermatologists here, that the pathologist can single-handedly deliver a diagnosis on these cases. Most of these cases would fit the histologic, some of them molecular criteria for mycosis fungoides or other lymphomas. But as we all know by now, the clinical correlation is essential. Repetitive biopsies are also essential. And many times PCR clonality helps clarify things. Not all of them, as you have shown, but many. And one more point for Cesare, as you have said, I would also like to stress the difficulties we dermatopathologists face in diagnosing these cases. I had a similar case where there was a case with an erythrodermic patient, and in 2 repetitive biopsies, I could not make the diagnosis of Sézary syndrome. And I thought it was chronic actinic dermatitis with PCR clonality studies negative, and this patient proved finally to have Sézary syndrome because he developed in the blood all the cells and the ratios, all of this, which were confirmative for this diagnosis. Yeah.
Yeah, I think, it's a team. I don't know if you guys watch football, but like my city's team just won the Super Bowl. So, but it's a team. Even though you have, you know, the diagnosis has to be made by us, you really need all the different people around. Sometimes you need the past people who've seen it and you look at the records. You need you to take several biopsies. Maybe we share cases. So a lot of times it really takes a team to make to win the diagnosis. Anyway, thank you for staying awake. A lot of path.
Thank you very much.